who present with Turner syndrome are short. Most of them have ovarian failure at some point, and there are other characteristic features. It's not an inherited disorder, but usually results from the loss of chromosomal material that can occur during oogenesis or spermatogenesis, when females make eggs and males make sperm, or early on in embryonic development. So this is an example. These are examples of what Turner syndrome might look like. Some of these girls can look like quite normal with no typical features, and then there are others who do have more traditional features that we see in more severely affected girls and women. Here we have somebody who really doesn't look like she has anything, but probably presented because she was small. When we look at a karyotype, and that is when we look at the chromosomes in people, we note that we have 23 pairs of chromosomes. So everybody has 46 chromosomes. You get 23 from a mother and 23 from a father. And typically, girls have 2 X chromosomes, and boys would have 1 X and 1 Y chromosome. In Turner syndrome, the classic form, the girls have usually missing an entire X chromosome. So they will have inherited, or they will have lost, they will have inherited either 22 chromosomes minus 1 X from the mother or the father, or one of the X chromosomes might get lost during the development of the embryo early on. But so Turner syndrome is when you have the complete or partial loss of one of the X chromosomes. And the more common type of Turner syndrome is where you lose 1 X chromosome from some of your cells, and you have other cells that have both X chromosomes. Girls who present with what we call mosaic Turners will come to us usually just because they're small. They might have other features that are consistent with Turner syndrome, but they can be difficult to diagnose depending on how many cells in their body have only 1 X chromosome, which is represented in these lighter images. So girls can have different versions of Turner, making it even more difficult to diagnose. So when we suspect that somebody has this disorder, we do this karyotype, and sometimes we find that some of the cells have only 1 X chromosome, and others have 3 X chromosomes because of a problem with the division of the cells early on in development. Then we also see girls with Turner syndrome who might have some Y chromosome material. And these girls are also mosaics, but they fall into a special category that we'll discuss in a little bit. Okay, and then making it even more difficult sometimes to tell are the girls who might look like they have nothing wrong with them, but they don't grow, so they get referred to pediatric endocrinology because they're short with no other typical features, and they're just missing a part of 1 X chromosome. Okay, so what exactly is Turner syndrome? So Turner syndrome, and this is the classic form where a girl has 45 instead of 46 chromosomes because she's missing an X chromosome. Almost all of them, 100% of them, come to us because they're small. Most of them, at some point or another, have ovarian failure. Many girls with Turner syndrome are born with puffy hands and puffy feet because the vessels called lymph vessels in the body don't develop normally, so fluids aren't transported through circulation the way they should be. And as a result of that particular problem, we can see some webbing. We call this a web neck. And that it develops because during fetal development, because circulation isn't normal, because the lymph vessels don't develop normally, fluid can accumulate in the neck and then also in the hands and in the feet, which I'll show you in a little while. The excessive fluid can also cause some deformities in the chest. So the girls sometimes have, or depending on their chromosomal, depending on their karyotype, the more affected girls have widely spaced nipples and what we call a shield chest. The arms are affected. They have what we call a wide carrying angle, so the arm really can't straighten out fully because of the fluid the abnormal circulation. The ears don't develop the way they should, and we can see low set ears, and oftentimes we see widely spaced downward slant of the eyes and ptosis, which is drooping of the eyelids. In the mouth, we see what we call a high-arched palate, but really it's a narrow palate, and that can cause some teeth crowding. Because of the ear issues and the narrow palate, drainage of fluid from the ears can be a problem. So many of these girls, when you take a history, have had long-standing chronic issues with ear infections and can have hearing problems as a result of that. The girls with Turner's are also more susceptible to autoimmune disease, which we'll discuss. They tend to develop moles. They can have bone loss, difficulty learning, and weight problems, and even metabolic issues that can lead up to type 2 diabetes. So because of the edema and the webbing of the neck, the hairline doesn't develop normally, and so we can see that the hairline is rather low in this girl. And we talked about puffy hands and puffy feet. Sometimes the feet can get so puffy that the toes are misshapen. The nail beds can be abnormal because of the fluid. So sometimes these nails lift off the nail bed. And then this is an example of the malocclusion that we might see in girls with Turner syndrome because their palate is narrow. So oftentimes an orthodontist give these girls palate expanders, which a lot of kids get, but problems that an expander can help. This is the puffy hands, another example. And we also see a shortened fourth metacarpal. So these are your metacarpal bones in your hands, and this one in particular is short. I don't know why. I don't think anybody really understands why this one in particular is affected, but it is. And we can actually see something that we call a Madelung deformity, where the end of the ulnar bone can get a little puffy and stick out. Girls with Turner syndrome, as I mentioned, can have ptosis, which is the drooping of the eyelids, but they can also have strabismus, so it can lead to lazy eye. And so ophthalmology is always involved in girls who have those issues. And then they can also have nearsightedness or farsightedness. We talked about moles. These are halo nevi, where you lose a little bit of pigment around the mole. They can be seen in other situations too, not just Turner syndrome, but we do see them in girls with Turner. They have to be screened for what we call coarctation of the aorta and bicuspid aortic valve. About 50% of girls with Turner syndrome are born with some congenital heart disease. This is what we would call a coarctation of the aorta. The aorta is the major vessel that comes from the heart, the left ventricle, and feeds the oxygenated blood to the rest of your body. And there can be a narrowing here, which can cause a lot of problems, namely high blood pressure and poor delivery of blood to the rest of the body. Sometimes, given how things develop, a bicuspid aortic valve is found. An aortic valve, which is the valve that separates the left ventricle from the rest of the circulation, has it should have 3 cusps, and if it has 2, that can eventually cause problems, and it's sometimes associated with this narrowing here that we see. So girls with Turner syndrome, once a diagnosis is made, if they don't have known heart disease, they are always referred to a cardiologist so that they can be appropriately monitored. And this is what a normal aortic valve looks like, and this is the bicuspid aortic valve that we talked about. When a cardiologist gets involved, we expect that there'll be regular follow-up for girls who have Turner syndrome, even if they don't have any obvious problems, because they are at higher risk for problems with their aortas. They can dissect or develop aneurysms. High blood pressure is not uncommon, and early cardiovascular disease. And there is some suggestion that the increase in stroke risk may have something to do with an increased risk for clotting, but I don't think people know too much about that, so that's a little controversial. Kidneys can often be affected in girls with Turner syndrome. The more common abnormality is what we would call a horseshoe kidney. And if you have a horseshoe kidney, and you don't have to have Turner syndrome to have a horseshoe kidney, as long as your kidney function is normal and you don't have a lot of urinary tract infections, a kidney specialist or a urologist or nephrologist doesn't have to follow the patient. So a renal ultrasound is absolutely necessary when you make a diagnosis of Turner syndrome, because 25 to 40% of Turner patients have abnormalities. But what I should have written here is that they should be followed by nephrology if they have functional problems with their kidneys, and by urology if they tend to have problems with urinary tract infections, because if they do, then it's usually because of a structural abnormality causing reflux into the kidneys. One of those might be a duplication of the renal pelvis, where this ureter coming off the kidney and draining into the bladder is duplicated. That can cause problems because there can be poor emptying and reflux back into the kidney. So a pediatric endocrinologist will get involved in girls with Turner syndrome because all of them come to us since they are small. So sometimes they don't have any of the typical features that we see in most cases of Turner syndrome. They're just small. And this is a growth chart that represents girls with Turner syndrome. And this in red represents the normal growth chart. And over here is the spectrum that we tend to see in girls with Turner syndrome. So you can see how much smaller girls with Turner syndrome tend to be. We start treating girls as early as possible with growth hormone if they are diagnosed with Turner syndrome. Usually try to start as early as 4 or 6 years old if they're short to begin with. There are some exceptions where girls don't start off short, but then fall off the chart later on. But we can add typically around 8 inches of final height potential if we start early. And of course that depends on your parents. I once had a patient whose parents were very tall. Mother was almost 6 feet, father was over 6 feet. So she only needed growth hormone for a short time because she was on the growth chart for most of her growth years. When we have girls on growth hormone is given as an injection every day. We monitor these girls every 4 to 6 months to make sure that they're doing well and responding well and keeping up with, so that we can keep up with their doses. We continue growth hormone for as long as the growth rate continues to be over an inch per year. And initially, these girls can grow quite a few inches per year, and then slow down to the normal 2 inches per year or so. As I mentioned earlier, puberty in Turner syndrome, most of the girls who have Turner syndrome do not have spontaneous puberty because their ovaries don't work. With ovarian failure, we see in almost all of Turner syndrome patients, many of the girls just don't start puberty. Some of them start puberty but aren't able to continue normal puberty because their ovaries fail normal puberty. Sometimes ovarian failure doesn't occur until the reproductive years. But for the girls who are unable to start puberty on their own, we do initiate low-dose estrogen that we start around 11 or 12 years old. And then we titrate the estrogen doses up very slowly. The recommendations now are not to use pills, but rather patches, transdermal patches, that we will start by cutting up a patch into several pieces and using a small square every few days, and then gradually move up over the course of a few years. We don't want to give them too much estrogen too quickly because that can curtail growth potential. So we do this slowly. We also want girls to develop normal breasts, and so going through slow and steady increases in estrogen, that's very important for breast development. And as I mentioned, some of the girls can actually have the spontaneous breast development, but ovarian failure before completing puberty, that number in mosaic Turner patients is about 30%. We start adding oral progesterone about 2 years following the initiation of estrogen, or sooner if there's vaginal bleeding. The progesterone is what stabilizes the uterine lining. The lining of the uterus proliferates and gets thick and then sheds as part of a monthly cycle in girls when they have their periods, and women. And the progesterone helps to stabilize that lining, and in combination with the transdermal estrogen, we can cycle girls, give them menstrual cycles. Girls with Turner syndrome are at higher risk than the general population for scoliosis. So especially when these girls are on growth hormone, we want to watch them carefully because spine growth is one of the risks for scoliosis. In children, adolescents tend to have scoliosis more frequently than younger children because that's when spine growth really happens. And in girls with Turner syndrome, if you add growth hormone, and even if you don't add growth hormone, but certainly with growth hormone, the risk for scoliosis is higher, and so they need to be followed and referred to a specialist if necessary. We talked about the ears in girls with Turner syndrome. There is this higher rate of infection from infancy on, and that often precedes the diagnosis of Turner syndrome. We talked about when you make a diagnosis of Turner syndrome, parents, they can daughters have had a lot of ear infections, and they need laryngotomy tubes. Aside from the risk of hearing loss because of chronic ear infections, girls with Turner syndrome also have a higher risk for sensory neural hearing loss. And so even if their hearing is fine and they've grown out of having ear infections, we will recommend hearing tests every few years to make sure that they don't need assistance, and to make sure that if there is sensory neural hearing loss, that they are appropriately referred to the audiologist. Girls with Turner syndrome are at higher risk for developing autoimmune disease, particularly thyroid. Autoimmune thyroiditis is probably the most common autoimmune disease there is in the general population, and definitely so for girls with Turner syndrome. So we monitor thyroid function every year after diagnosis, because about 30% of these girls go on to develop autoimmune thyroid disease, usually an underactive thyroid. About 1% of the general population has celiac disease. Celiac disease is when the immune system attacks part of the small intestine in response to wheat gluten. This is not an allergy or a hypersensitivity. This is actually an autoimmune disease that's triggered by the gluten causing the immune system to attack part of the small intestine that is responsible for absorbing nutrients. Sometimes there are no symptoms before you're making a diagnosis. So in my own practice, I like to screen girls even if there are no symptoms. I've actually made a diagnosis of celiac disease in quite a few girls with Turner syndrome. The girls with Turner syndrome do also develop type 1 diabetes, but the risk for this autoimmune diabetes is really not that much higher than that of the general population. As I said before, the thyroid is the more common disorder that we see. Girls with Turner syndrome also have a higher rate of liver enzyme elevation. So I like to check these annually. There is an unexplained reason for this most of the time, where we will just see this elevation that a lot of liver specialists will just chalk up to having Turner syndrome. But some of it might be related to being overweight, as girls with Turner syndrome are likely to be. They might have bad lipids, and some of them go on to develop autoimmune hepatitis, which is managed by a liver specialist. And also estrogen deficiency can cause liver enzyme elevation. As I mentioned before, girls with Turner syndrome are at higher risk for obesity, problems with cholesterol and triglycerides, and type 2 diabetes. So it's very important that nutrition education be part of the follow-up for these girls, and that they're annually screened for type 2 diabetes, usually with a fasting blood sugar and a test called a hemoglobin A1C, and a lipid profile. Sometimes we'll go further if we're uncertain and get a glucose tolerance test. Girls with Turner syndrome are also more likely to develop metabolic bone disease because of estrogen deficiency and other reasons. So we optimize vitamin D and calcium supplementation, and we do bone density scans every 5 years. Sometimes I start before 18 years, but usually not until we're done finishing, not until the girls are done with puberty. Girls with Turner syndrome can go on and have children, but they're at very high risk, and these would be girls who still have ovarian reserve. They really need to be followed carefully, because those with cardiac issues, particularly aortic issues, can develop a lot of complications. Up to 7% of women, these would be mosaic women who don't have a complete absence of one of their X chromosomes. Some of them can actually get pregnant with their own eggs. Risk of miscarriage, though, is high, up to 45%. Risk of preeclampsia is more than double than in the general population. And because of the underlying genetic disorder that girls and women with Turner syndrome have, more than 30% of these pregnancies are going to have fetal anomalies. For girls who still have some function in their ovaries and are at least 12 years old, there are centers that do cryopreservation of eggs, so that may be an option to preserve fertility. But unfortunately, this is relatively new, so there really isn't much outcome data there yet. And for those girls who have a tendency for aortic aneurysm or dissection, as I mentioned before, pregnancy needs to be avoided. If anybody with Turner syndrome is interested in having a child of their own, this needs to be discussed carefully with their treating physicians to make sure that it's a safe option. Learning and behavior. Girls with Turner syndrome may have developmental delays, so that could include OCPT and speech. Neuroscience testing is recommended starting in preschool and when needed, because it would be good to get an IEP or an individual education program started as soon as possible. 25% of the girls with Turner syndrome have ADHD, and up to 75% of girls with Turner syndrome have math. I don't know why math, but that's what we see. They may have particular strengths in reading and language, but math is usually a problem. Overall, girls with Turner syndrome can attain the same level of education as the general population. So in summary, Turner syndrome is a disorder requiring lifelong multidisciplinary monitoring, and girls with Turner syndrome who are identified and follow regularly with their physicians do well. Are there any questions?
More seconds, yeah.
Okay.
The people on live can't hear it. I don't know why. I don't know.
I think that's been about 30 seconds.
Yeah, it's been about 30.
I will pass the camera and microphone on to Caitlin.
Thank you. Hi everybody, I'm Caitlin. I actually have Turner syndrome myself, and Dr. Levy was actually my doctor for most of my life.
How do we get that next part? Let's see. Gosh.
There we go.
There we go.
Okay, so these are a few pictures I took so you guys can kind of see how little it was before my diagnosis of Turner syndrome, and kind of see, like, if you look here in the middle picture, you can actually see the edema in my feet. And you can kind of look, if you go to the right picture, that's me when I was 4 years old. I had my tonsils removed and my adenoids, and so that's how little I was at 4. I decided I'm going to start off with medical issues that I currently have today. I do have halo moles, as Dr. Levy was talking to us about. And as you guys know, I have Turner syndrome. I do have ADHD. I have a mitral valve prolapse, and I have a vitamin D deficiency. I have sleep apnea, constructive airway disease, and asthma. I have IBS, Raynaud syndrome, autoimmune hepatitis, a pre-ovarian failure. I have mild scoliosis, and I have hypercholesterolemia, which is essentially meaning that I had high cholesterol from birth. Basically, I do have a lot of autoimmune issues linked to Turner's, and as you can see here on the slide, that is a picture of me with my CPAP machine, so you guys can kind of see what I kind of go through on a nightly basis. And I'm going to kind of give you guys an overview of my doctors really quick, because I feel like that's so important, especially because this gives you a reality of my life. And I see this whole list of doctors that you see here every 3 to 6 months. So every 3 to 6 months I go see all of them doctors. And then if you can look on that picture before I read you guys that list, that is literally my life. That is 12 vials of blood, if not 14. And that is what is my average on blood work getting taken from me. So as you guys see, I do see a PCP, as you guys would. And then I see an ENT, and I see an allergist, a sleep specialist, a dermatologist, a gyno, like any ordinary other female would, an endocrinologist, as you know, that's for my Turner's. Gastroenterologist is for my liver, because I have autoimmune hepatitis, and there's a few other issues that I run into every now and then, so that I have to go see a gastroenterologist for. I do have a mitral valve prolapse, so because of that, I do also have to see a cardiologist. Pulmonologist, I do have to see because of all my lung issues, and sometimes doctors who are pulmonologists will also actually take over for your sleep doctor. In my case, I have them separate. And then audiologist, and that's so important, guys, especially if you have Turner syndrome, because as Dr. Levy stated before, we do have a chance of losing our hearing, unfortunately. And then, so it's really important every couple years, as she said, but there are certain guidelines for Turner's that recommend after a certain point of your age for different lengths, periods of times. And then I see an ophthalmologist for glasses, contacts, and stuff like that. And I decided to put next is a list of the operations that I've had, so you guys can kind of see around about what I had to go through. I had to put my ears at 3 because of a lot of ear infections, but we'll get into that a little bit later. And as I stated before, I had my tonsils and adenoids removed. I've had a colonoscopy. I've had an upper and lower IG. I had a deviated septum repair, and they also shaved a little bit of the bone in my nose. I had a gallbladder removal. I've had a liver biopsy. I've had a birthmark removal, and I had dry needling done. And that picture that you see here on your screen is actually, sorry about that, guys, is actually me and my grandma for my liver biopsy. And as you can tell, you're awake and alert for that. And the other testing that I get done that is super important is I had a lung function test done, which as you see here on the picture, I gave you guys an example because not a lot of people actually do know what a lung function tests are. So there's me doing the lung function test, and again, I also did the same picture as you did before with the amount of blood work. I have had to have 3 sleep studies at this point. I have had bone density scans, hearing, blood tests, CT, MRI, an echo, a Holter monitor, and bone age test I did have before as well. These are a little bit, I decided to put a few pictures so you can kind of see here a little bit of from the surgeries. This picture on your left is me in recovery from my gallbladder removal. And then the middle picture there, as you can see, I just kind of made it so you guys can see my incisions and stuff like that. And the picture on the very end there is actually me before an operation, and that's just to kind of show you about some of the anxiety that I face with those sorts of particular situations, because I do also suffer from anxiety. And then treatments I've had to undergo was I've had to have growth hormone therapy, I had to have speech therapy, estrogen replacement therapy, birth control, braces, and expander. And then I'm going to go to my baby years and kind of explain essentially why we were testing about my Turner's and why like all this and that would happen. So some Turner kids are actually fail to thrive babies, and I was one of those fail to thrive babies. My mom would always tell me it took me 2 hours to just eat those like 4 to 8 ounces or whatever the ounces were, and then I would be like hungry. She thought I was colicky, but it turns out it wasn't really that, because I was just hungry because I couldn't really eat properly. And then I didn't really meet my milestones on time, like ever. And then because I couldn't eat properly, and because for the diagnosis of fail to thrive, I actually developed thrush in my mouth because I couldn't, like swallow properly and everything else like that. And then after I was like 2 weeks old, I actually had to go, I had a lump on my head, and we have no idea what that was about or why. And I actually, in my life, have, like, when I was a baby, never crawled. I refused to crawl. And I didn't even start walking till I was 18 months old. And one thing I put on here is I was always sick and am always sick. You guys, I can't stress that enough. Like, every time I turn around, I'm sick. I got something going on. And that's really important, I think. And this picture there with me with the cute little telephone there on that slide is actually me when I was, again, 4 years old. I was the size, at the age of 6, I was the size of a 2.5-year-old. So, going to my toddler years, and if you see that picture on the slide, that is actually me at the age of 3. So before, as Dr. Levy mentioned about a lot of ear infections, I was one of those kids that did develop a lot of ear infections. I hummed all the time, and it was to the point where one year of my life, I had a teacher call me like the mad hummer, but I'll get into that a little bit later. I was more like I entertained myself kind of kid, and where I was like stayed to myself more than anything. And my tonsils were like really big in my toddler years, so I had to get my tonsils and adenoids removed because I couldn't eat properly. I'd have to eat and like spit it back up and eat it again, which is gross. So I apologize if that grosses you out. Trust me, I think it's gross myself. And then I had to go through speech therapy, and I had to go through occupational therapy. These are a few pictures of my childhood that I thought to add on there for you guys. So again, you can kind of really see how tiny I was. There I was about, I would say about 4 to 5 in those pictures. Right there. I'll give you a minute to look at that. So I'm going to talk a little bit about schooling. And I just showed this picture is me in preschool. Anyway. So I didn't really have friends in schooling. Like, I really didn't make friends easy at all, and a lot of times I was actually bullied. I was held back as well. I went to T1, transitional first grade, and I had what's called spatial learning. Sorry, it's a little hard to pronunciate that. And then I had, like, and I put this way, phrased it on the slides, nothing crossed over center of the body. And what I mean by that is, if it was on the left side of the paper, I'd write it with my left hand. If it was on the right side of the paper, I'd write it with my right hand. So I'm ambidextrous, too, is in other words. And I put on there I was bullied a lot. I really did. Like, if it wasn't about, me being short, if it wasn't about me being dumb, as kids would say. I mean, it was something or another that they would come up with. I was behind in math, particularly, but basically everything I was behind in, but math more than anything. And I did, thank goodness, I had an ISP and an IEP at one point. I did go in learning support. I had to go full time for elementary school, and then like towards the middle school, I was doing part time, and eventually, by high school, I really was barely in it at all, except for like one class, maybe 2. I struggled a lot with comprehension through schools. I don't know why, but I did get decent grades though. Like, my grades were basically A's and B's, and I was pretty good in that route. So I'm going to kind of talk to you about a little bit of my teenage years and how it's different than a normal girl's teenage years here. So let's talk a little bit about puberty. As Dr. Levy mentioned about our puberty is different than the girls with like normal girls with their puberty. I never developed by myself. I had to get put on estrogen replacement therapy, and I had to also put on for birth control after that, because I didn't get my periods. I really didn't develop at all, and I even, talking about a few of these things that normal girls, because then you're in your teenage years, and then, a lot of times sex is in the questions for these females. Not for me. I had sex education comprehension issues where I didn't really understand a lot, nor did I honestly really care. Honestly. And then if you go on to the dating there with teenagers, that was a struggle. Because one, I was sick, had a lot of doctor's appointments, to be honest, and the other portion was I have really bad anxiety altogether with the dating spectrum, and most of it is more how I can describe to you guys as like, I would look at someone and be like, oh, he's gonna leave me. Like, he's seriously gonna leave me. And any little tiny fight that would goes through my mind, and then it's, if he wasn't gonna leave me, it's, oh my god, he's not gonna want me. Like, look at him looking at that girl, and it could not even be looking that much at another girl, and it would still, to me, it was like that. And so dating was not the best part or funnest part, and still is not to this day. So let's talk a little bit about driving, because driving is obviously a normal part of any development from everybody. A lot of Turner girls actually have issues driving. I did too, because I had issues with judging like space between cars, space between buildings, if you were parallel parking, and that scared me driving, to be completely honest with you guys, because it was something that obviously I love driving now, but it was something where like at first I did have a lot of anxiety about it, and my mom had to teach me a lot about that stuff, and I decided on this slide to put a picture of me and my mom. She has been a huge supporter of mine. She's been to like every appointment, every operation, like, and that's so huge. And especially whenever I was struggling with like this sexual comprehension and the dating, my mom has been there, like my mom made it like an open book policy at our house. And especially with me and with the Turners and her explaining maybe why I didn't understand something, and she was basically the one who taught me how to drive, and so that's like super important. And then I put a picture of me in the hospital bed because, I was in the hospital a lot, and my mom was always there. So that's like really important for anybody really who would go to the doctors or hospitals or whatever that you would have to go to. So, as you guys know, when you're a young adult, you move out, you go and you have serious relationships and all of this and that, and then you have to go from a kid doctor to an adult doctor. So I'm going to talk to you a little bit about that particular situations. These two pictures I have here are actually from my young adulthood there. So let's talk about moving out. So normally, it would be easy to get a good job, move out. I was very honestly thankful, and I was very lucky because I did get a good job and I was able to move out. My struggle with that was really financially, because like it's your first big job, especially when I was so young. Now I don't struggle with this as much, like I would have money, I would just want to go and travel and go here, there, and everywhere, like anyone really wants to, and I would make it happen. And then it was like I had anxiety because I was alone, like in my like the place, and you don't really think about that when you're going to move out either. And so for me, it was like this crazy, like I got bills for the first time in my life, but then like I'm alone for the first time in my life. It was honestly like a scary moment. I did go to college, and I did really well in it. Unfortunately, I had to medically drop out. I did make the dean's list, or I would have, I should say, before I had to medically drop out. To me, I do better when I learn, like I teach myself, I can do really good. Or if you hand me a book, I read it, I can do it. Or like if I hands-on, like you're showing me literally how to do it, I can do it, and I can do it amazing. So the serious relationships. This is a huge struggle. I face this to this day, and I'm always going to face this, to be honest, because of how bad my anxiety with that was, which I talked a little bit about it. But then, for the first time I did actually move in with a guy. So that was my first experience with that. So, basically, for me, I already struggled being in a relationship and then moving in with him. It wasn't too terrible, to be honest with you. Like, it was a little bit hard because, like, I'd want attention, and he would be busy playing his Xbox, and then I would be like, oh gosh, he doesn't want me. He's playing that Xbox. Like, a lot of us turn around low self-esteem, and I'm one where I don't really have low self-esteem too much, but when it comes to relationships and everything else, I'm like, yeah, I might be okay looking, but then that girl's way prettier, so she's gonna win. Even though it's not even like a test in and of itself, But that was hard. And then plus, like, as you saw in this picture down here, like, that was our little family, type feel that we had, with our dogs and cats, and, it was cute, and it was cool while it lasted. But anyway, that's a different story. And then doctor differences. Honestly, going from pediatric doctors to adult doctors is really difficult for me because, like, I love Dr. Levy, and she's been with me since I was 5 years old. So to find someone else that fits the criteria that I want, like, you finally have doctors that know your story, know your book, know your cases, to just have to start all over again, them not even know my name, and then eventually know my name, but then to know how serious of the health issues I have and for me to trust them, because, like, doctors I'm super picky about. Like, you have, like, one shot with me being a doctor, and if I don't like you, I won't come back. And it's because, like, I'm so, like, picky. Like, I've had really amazing kid doctors that they have set such a high mark for doctors in my life, and I honestly, I still struggle to trust them doctors. I did find a few good ones now, so that's huge, but in general, it is a huge difference between kid and big doctors, and it's a different aura as well, I feel like, as well, for me. So, does anybody have any questions here for me, maybe about, like, something maybe you don't feel like I covered, that you want to know about? Because I'm an open book. I'm trying to think if I think I covered basically everything. So. Okay. Well, I want to thank you guys for watching the presentation, and that means so much to me, and I hope you guys have a good afternoon.
I guess that ended. Was that noise
How
the
was
end of
it?
it?
What's that?
Great.
You liked it?
Really good. Yeah, you're a very natural speaker.
Oh, thank you.
Say bye to your people.
Bye, everybody. Thank you so much for watching. Come with me real quick.
Oh, no, I'm good.
Well, this girl made it happen, made all this possible for this, my dream be happening. And I hope you guys have a good afternoon. I'll respond to all of you guys later on in the day when I have some spare time. But thank you so much for watching. That means everything to me. I love you guys. Thank you.